Professor, let's chat. I'm looking for a cure for cancer. Talk to me. What can you come up with? Spark an idea.
My honest professor answer: there probably won't be one cure for all cancer, because cancer is not a single disease. Modern oncology keeps moving toward precision medicine, matching treatment to the tumor's biology. And immunotherapy is already proving that in some cancers, the immune system can do astonishing work. The idea: don't aim first at the giant visible tumor. Aim at the last hidden cells after initial treatment. If I were trying to spark a real cure cancer program, I'd build a platform around this sentence: catch relapse before scans can see it, then hit microscopic disease with a personalized immune attack before resistance has time to organize. Why that target? Because blood-based ctDNA/molecular residual disease (MRD) testing is increasingly being used to detect tiny amounts of cancer left behind after treatment, and trials are actively using ctDNA to guide who should get extra therapy. That means medicine is getting better at finding cancer when it is small, scattered, and more vulnerable. What this would look like: remove or shrink the main tumor with the best current method for that cancer. Map the tumor deeply to find its mutations and immune weak points. Watch the blood frequently for ctDNA, so recurrence is caught at the molecular level instead of waiting for a scan. The moment ctDNA turns positive, launch a personalized anti-relapse package, a neoantigen vaccine tailored to that patient's tumor, plus the right checkpoint immunotherapy or cell therapy, plus adaptive dosing. So treatment doesn't just wipe out sensitive cells and leave resistant clones to take over. At the same time, use a local treatment designed to reprogram the tumor microenvironment, especially macrophages and dendritic cell signaling, so the immune system can actually see and finish the job. Research is increasingly showing that changing that local immune environment can matter a lot in solid tumors. Why I think this is the right battlefield. We already have proof of principle pieces, some dMMR/MS. H tumors can respond dramatically to immunotherapy, to the point that immune-only treatment has completely eliminated primary tumors in some rectal cancer patients. Personalized neoantigen vaccines are showing encouraging early signals in cancers like pancreatic and kidney cancer, especially in preventing recurrence after surgery. Adaptive/evolutionary therapy is a serious research direction built around the fact that resistance is often the real enemy. Instead of blasting blindly, it tries to control tumor evolution. In plain English, my spark is this: stop asking, how do we destroy every cancer cell at once? Start asking, how do we detect the comeback early enough to kill the last 1,000 cells before they become the next billion? That is where cure starts to sound less like a miracle and more like a systems engineering problem. If you want, I'll take this one step further and turn it into a one-page moonshot to cure cancer concept sheet with the core invention, how it would work, what technologies already exist, and what breakthrough is still missing.
Okay, would you take it one step further?
Absolutely. Here's the next step version, not just a spark, but a moonshot concept sheet. Project Sentinel Strike, a relapse kill platform for curing cancer one hidden cell population at a time core thesis. The fastest path toward more real cancer cures is probably not a universal drug. It is a system that finds molecular relapse before imaging can see it, then launches a personalized immune attack while the remaining cancer burden is still tiny and less genetically diverse. That direction is grounded in current work on ctDNA/MRD detection, personalized neoantigen vaccines, and immune-based therapy in select tumor types. The invention built a platform with 4 linked parts: tumor map, sequence the removed or biopsied tumor to identify mutations, clonal structure, and targetable neoantigens. Personalized immunotherapy programs already use tumor-specific mutation data to design vaccines or cell-based approaches. Blood Radar monitors ctDNA after surgery or first-line treatment to detect molecular residual disease early. FDA guidance now explicitly addresses using ctDNA in early-stage solid tumor drug development, and NCI trials are already testing ctDNA-guided care. Personalized Strike package, When ctDNA turns positive, trigger a patient-specific combination such as a neoantigen vaccine plus checkpoint blockade, with the exact mix chosen by tumor biology. Early clinical reports in pancreatic and kidney cancer suggest therapeutic vaccines may help prevent recurrence after surgery. Evolution control layer: do not always dose at maximum intensity by default. In selected settings, adapt timing and intensity to reduce the selective pressure that lets resistant clones dominate. Adaptive/evolutionary therapy is being actively studied as a way to delay resistance. Why this is smart: cancer usually becomes hardest to cure after it has had time to branch, spread, and evolve resistance. A microscopic relapse state is a better battlefield. Fewer cells, less heterogeneity, less physical shielding, and more chance for immune clearance. That is partly why ctDNA-based MRD detection is such a big deal. It moves treatment decisions earlier in the relapse timeline. We also already have proof that in the right biological setting, immune therapy can do something that once sounded impossible. In mismatch repair deficient rectal cancer, PD-1 blockade with dostarlimab has produced complete clinical responses in a phase 2 program, showing that some tumors can be eradicated without standard surgery, chemotherapy, or radiation. That is not all cancer, but it is a powerful existence proof. What makes this different? Most cancer care still revolves around treating what can be seen on scans. Sentinel Strike would treat what the blood says is returning, even when the scan is still clean. That flips oncology from a visible mass model to a molecular ambush model. The aim is not just shrinkage, the aim is extinction of the comeback. The feasibility of this shift is supported by NCI ctDNA-guided trials and FDA's recent regulatory work around ctDNA use in early-stage solid tumors. Best first targets. This should begin where biology and logistics are strongest: post-surgery pancreatic cancer and high-risk kidney cancer, where personalized neoantigen vaccine signals are already encouraging. Triple-negative breast cancer or other high-risk early-stage tumors where ctDNA surveillance trials are underway. DMMR/MSI-H tumors, because they already show unusual sensitivity to checkpoint immunotherapy. The missing breakthrough. The hardest unsolved piece is solid tumor immune failure. Even when you know what the tumor looks like, the tumor microenvironment can suppress T cells and block durable responses. That is why I would add a fifth optional module over time: microenvironment reprogramming, especially macrophage-focused or dendritic cell-supportive strategies to turn cold tumors hotter. Current NCI and Nature family sources both point to the immunosuppressive microenvironment, especially myeloid cells/macrophages, as a major barrier and an active therapeutic target. How I'd run the first real pilot enroll patients after apparently successful first-line treatment. Sequence each tumor. Start scheduled ctDNA checks. The moment ctDNA becomes positive, randomize between standard adjuvant/escalation care versus a personalized strike package triggered by the ctDNA result. Measure ctDNA clearance, recurrence-free survival, time to radiographic relapse, overall survival, toxicity, and cost per relapse prevented. Those endpoints line up with the way FDA and current oncology trials are increasingly thinking about biomarker-guided development in early-stage disease. Plain English version. Here's the whole idea in one sentence. Don't wait for cancer to come back big enough to photograph. Kill it when it's only big enough to whisper in the bloodstream. That is the step beyond the spark. And here is the deeper truth. This would not be. I can turn this next into a Garage Inventor version in plain language.
A Garage Inventor version in plain language. Okay, talk to me about it in plain English.
Absolutely. Let's strip the lab coat off it and put it on a workbench. Garage Inventor version. Catch cancer early, hit it smart, and stop it from coming back. The simple idea: instead of waiting until cancer comes back big enough for a scan to see it, watch the blood for tiny signs that it is returning. Then, the moment it shows up, hit it with a treatment made for that person's exact cancer. That's the whole play, not wait, let it grow, then fight a big battle. But watch closely, catch it, tiny, kill it early. Why this makes sense. Think of cancer like a fire. A big fire in a forest is hard to stop. A few sparks in dry grass are much easier. Most cancer treatment today still ends up fighting the fire after it is visible. This idea says, don't wait for flames, hunt the sparks. How it would work. Here's the plain English version. Step 1. Learn the enemy. When doctors remove a tumor or biopsy it, they study it closely. They ask, what mutations does it have? What makes it different from normal cells? What weak spot can be attacked? That gives you a kind of wanted poster for that cancer. Step 2. Set up a blood alarm. After treatment, the patient gets regular blood tests. These tests look for tiny pieces of tumor DNA floating in the blood. That is like putting a motion detector around the house after a burglar leaves. If the blood stays clean, good. If tiny tumor traces show up, that means cancer may be trying to come back. Step 3, hit before it grows. Now don't wait 6 months for a scan. The second the blood alarm goes off, launch the attack. That attack could include a custom vaccine made to train the immune system on that exact cancer immunotherapy, to take the brakes off the immune system, maybe other drugs chosen for that tumor's weak points. So instead of swinging blind, you are using a smart missile, not a club. Step 4, don't let cancer outsmart the treatment. Cancer is slippery. If you hit it the same way every time, sometimes the toughest cells survive and become the new problem. So part of this idea is to treat cancer like an enemy that adapts. That means watch it, measure it, change the attack when needed. Don't always assume more drug means better outcome. What makes this different? Most people think of a cure as one miracle pill. I don't. I think the better idea is a system. Detect earlier, personalized treatment attack. Small disease keep adapting until nothing is left. That is much more like how a good mechanic, soldier, or inventor thinks. You don't pray for magic. You build a better system. The parts of the machine. If you were sketching this on a garage whiteboard, it would look like this. Part 1. Tumor blueprint. Read the cancer's code. Part 2. Blood radar. Check the blood over and over for tiny return signals. Part 3. Custom strike package. When the signal appears, launch the treatment matched to that cancer. Part 4. Smart control system. Keep adjusting so the cancer cannot easily evolve around the attack. What already exists? This is the exciting part. Pieces of this are already real. We already have tumor sequencing, blood tests that can detect tiny traces of cancer, DNA, immunotherapy, early personalized cancer vaccines, research on smarter dosing and resistance control. So this is not fantasy. The breakthrough would be tying all the parts together into one clean, fast, repeatable system. What is still missing? Here's the hard truth. Cancer hides well. Some tumors shut down the immune system around them. Some patients respond beautifully, others do not. So the missing piece is not just detection. The missing piece is this. How do we make the immune system finish the job every time? That is the big engineering challenge. Why I like this idea, because it stops chasing the dream of a single silver bullet. Instead, it says, let's build a cancer early warning and response system. That sounds much more real to me. It is like building a radar, a target lock, a custom weapon, and a feedback loop. That's not magic. That's engineering. One sentence version. Here's the garage door slogan. Find cancer when it whispers, not when it screams. If I were pitching it from a garage, I'd say, we're building a system that watches a patient's blood for the first sign cancer is coming back, then launches a personalized immune attack before the cancer can rebuild. That is clean. That is strong. That is a real moonshot. What you might not see yet. The biggest idea inside the idea is this. The future cure for many cancers may not be one treatment. It may be a timing advantage. Catch it earlier than ever before. Hit it more personally than ever before. Never give it time to become a monster again. That is a serious idea.
Talk to me about blood-based ctDNA/molecular residual disease, MRD, testing.
I'm pulling this from a current cancer sources, so I can give you the real version, not the hand-wavy version, what ctDNA/MRD testing is, what it can do, and where the limits are. One important thing is already clear. This test is most exciting after surgery or other curative intent treatment, when the question is anything still hiding? Not, can one blood test replace the whole cancer workup? This is one of the most important ideas in cancer medicine right now. What it is, ctDNA means circulating tumor DNA, tiny fragments of DNA that tumor cells shed into the bloodstream. MRD means molecular residual disease, cancer that is still present after treatment but is too small to see on scans or with routine tests. In early-stage solid tumors, the FDA describes residual ctDNA after surgery or after neoadjuvant therapy as being indicative of MRD, plain English version. Think of it like this. The scan is the satellite photo, the ctDNA/MRD test is the smoke detector. A scan usually needs enough cancer to form something visible. A ctDNA/MRD blood test is trying to catch the disease when it is still microscopic, when it is only leaving a molecular trace in the blood. NCI and FDA sources both frame ctDNA as especially promising for post-treatment monitoring in early-stage curative intent cancer care, when doctors care about it most. This is not mainly a screening test for healthy people with no known cancer. The FDA's 2024 guidance specifically says that guidance is about ctDNA, use in early-stage curative intent solid tumors, not general cancer screening. The sweet spot is usually after surgery, radiation, chemoradiation, or adjuvant therapy, when the big question is, did we really get it all, or is something still hiding? What a positive result usually means a positive ctDNA/MRD result after treatment usually means there is a high chance some cancer is still present somewhere in the body, even if scans look clean. FDA says residual ctDNA after definitive local therapy and / or after neoadjuvant therapy indicates MRD and identifies a higher risk group for recurrence. In colorectal cancer, NCI summarized data showing ctDNA positive patients after surgery had a clearly higher risk of recurrence, and ctDNA status appeared to help identify who benefited from adjuvant chemotherapy. What a negative result means, a negative result is reassuring, but it does not prove there are zero cancer cells left. FDA explicitly notes that ctDNA testing can have false negatives, and that ctDNA levels vary depending on tumor type, location, stage, size, tumor burden, and response to treatment. That means some cancers shed very little DNA into the blood, so the test can miss disease that is really there. Why people are excited about it? Because it could help answer 3 huge questions better than we do now. Who really needs more treatment after surgery? Who can safely avoid extra treatment and its side effects? Who is relapsing before the relapse is big enough to show on imaging? That is why NCI is involved in multiple trials using ctDNA/MRD testing in early-stage cancers such as colorectal cancer, breast cancer, triple-negative breast cancer, and lung cancer. FDA also now has formal guidance for using ctDNA as a biomarker in early-stage solid tumor drug development. How the test is actually done? There are 2 broad styles: tumor-informed testing. Doctors first sequence the patient's tumor, then build a personalized blood test that looks for that tumor's specific mutations. FDA says the advantage is potentially higher specificity, but the downside is lag time and the risk that the panel may miss new mutations that appear later. Tumor-naive, tumor-agnostic testing. This does not depend on sequencing that patient's tumor first. It uses a broader fixed panel or other blood-based signals, such as methylation or fragment patterns. FDA says the advantage is faster turnaround, but the trade-off is that some tumors may not be covered as well by the panel. Why serial testing matters: one blood draw is helpful, a series of blood draws is much better. FDA recommends multiple ctDNA time points because changes over time can give a more robust signal than a single snapshot. Timing matters a lot because tumor shedding differs by cancer biology, and sample collection has to be standardized carefully for the test to be reliable, what it can do right now. Right now, ctDNA/MRD testing is most useful as a way to estimate recurrence risk after treatment, help guide clinical trials that escalate therapy for ctDNA positive patients or de-escalate therapy for ctDNA negative patients, and support closer surveillance for patients at higher molecular risk. In some clinics, it is already being used, especially in colorectal cancer, but NCI also quotes experts saying, "We still do not fully know how best to act on every result." For example, what to do when ctDNA is positive, but imaging still shows no visible recurrence. What it cannot do yet. It cannot yet fully replace scans, pathology, tumor tissue testing, or a doctor's judgment. FDA says more prospective randomized trials are still needed, especially if ctDNA is going to be used as an endpoint or to drive treatment changes broadly. Assay differences between labs also remain a problem, so standardization and harmonization are still major issues. The honest bottom line. This is the cleanest way I can say it. In ctDNA/MRD, testing is a blood-based way of looking for the molecular whisper of cancer after treatment. It is powerful because it may detect danger earlier than conventional methods. It is limited because earlier detection is not the same thing as a guaranteed better outcome, and the right response still depends on the cancer type, the assay, the timing, and the rest of the clinical picture. My professor hot take: this is one of the biggest shifts in oncology because it changes the question from, do we see the cancer yet? To, is the cancer already talking in the blood? That is a profound change. I'm comparing the three side by side so the differences are clear, because ctDNA/MRD is not equally mature in colon, breast, and lung cancer. That difference really matters. I've got the contour now. Colon is the most developed, breast is promising but more unsettled, and lung is exciting but still mostly a risk stratification/playbook building zone. I'm tightening the evidence so I can say that cleanly and honestly. Thought for 1 minute, 0 seconds, absolutely. Here's the clean breakdown of ctDNA/MRD testing in colon cancer, breast cancer, and lung cancer in plain language, but with the real medical differences left intact. The big picture. These three are not at the same stage. Colon cancer is the most mature use case right now. Breast cancer is promising, but treatment decisions based on ctDNA alone are still being worked out. Lung cancer, especially resected NSCLC, has strong prognostic data, but routine ctDNA-guided management is still less settled than in colon cancer. 1. Colon cancer. This is where ctDNA/MRD testing looks the strongest and most practical right now. In stage 2 colon cancer, the randomized dynamic trial showed that a ctDNA-guided approach reduced use of adjuvant chemotherapy without hurting 5-year recurrence-free survival or overall survival. In the 2025 mature follow-up, 5-year RFS was 88% with ctDNA-guided care versus 87% with standard management, and 5-year overall survival was also similar. Why that matters in plain English: after surgery, colon cancer patients are often stuck with a hard question. Do I really need chemo, or would I just be taking side effects for no benefit? ctDNA helps answer that better than older clinicopathologic risk factors alone. NCI's summary of the bespoke CRC data says ctDNA positive patients appeared more likely to benefit from post-surgical chemotherapy, while ctDNA negative patients had very good outcomes whether or not they got chemo. So for colon cancer, ctDNA is moving from interesting biomarker toward real decision support. But even here, caution still matters. ctDNA is strongly prognostic, yet it is not a complete replacement for scans, pathology, or clinical judgment, and guideline use remains more conservative than the excitement around the technology. FDA also stresses assay standardization and harmonization are still major issues. My plain English take: for colon cancer, ctDNA is closest to being a use-it-to-help decide tool, especially after surgery. 2. Breast cancer. Breast cancer is a little trickier. The signal is exciting, but the field is not as settled as colon cancer yet. A 2025 PubMed Index prospective study in high-risk early breast cancer found that surveillance ctDNA detection had 90.9% sensitivity, 98.8% specificity, and a median lead time of 9.7 months before clinical recurrence. That is a big deal. It means the blood can often whisper that relapse is coming long before imaging or symptoms catch up. But here's the catch: knowing earlier is not the same as knowing what to do next. A 2025 review notes that ctDNA-based MRD testing in early-stage breast cancer can detect molecular relapse roughly 8 to 12 months before clinical relapse, but also says more evidence is needed before broad adoption, especially because early-stage breast cancer often sheds very little ctDNA and requires ultra-sensitive assays. That is exactly why active trials are ongoing. NCI is running an active early-stage breast cancer study testing whether ctDNA-based MRD assessment can help determine care, including looking at post-operative MRD-only recurrence and ctDNA clearance after adjuvant chemotherapy or radiation. My plain English take: for breast cancer, ctDNA is already very good at saying danger may be coming. What is still being proven is, what is the best move when that happens? 3. Lung cancer. For lung cancer, the main evidence base is strongest in early stage or resected non-small cell lung cancer, NSCLC. A 2022 Annals of Oncology study concluded that ctDNA detection after curative intent treatment in early stage NSCLC has the potential to identify patients who may benefit from further therapy. In other words, a positive post-operative ctDNA test is a serious warning sign for relapse risk. More recent data keep pushing in the same direction. The 2025 LUNGCA study reported that dynamic ctDNA monitoring after surgery could inform whole-course post-surgical management of NSCLC, and found that ctDNA change patterns tracked recurrence-free survival. It also reported that some adjuvant approaches were better than others at clearing ctDNA, but lung cancer still has implementation gaps. A 2025 overview in NPJ Precision Oncology says MRD in early stage and locally advanced NSCLC is promising for adaptive management and surveillance, while also emphasizing that missing links still prevent widespread adoption. My plain English take: for lung cancer, ctDNA is very good at helping answer who is high risk after surgery. It is less established today for answering exactly which standardized next treatment should everyone get. Side-by-side summary: colon cancer, best current fit, deciding who may or may not need adjuvant chemo after surgery. Strength of evidence, strongest of the three, including randomized trial data. Breast cancer, best current fit, early warning of recurrence risk, and MRD tracking in high-risk early disease. Strength of evidence, strong prognostic, promise, but action plans after a positive result are still under study. Lung cancer, best current fit, post-operative risk stratification in resected NSCLC and possibly guiding future adaptive management. Strength of evidence, strong prognostic value but less standardized clinical action than colon cancer. The honest bottom line. If I had to say it in one sentence, colon cancer is the furthest along, breast cancer is the most emotionally dramatic because of long lead time detection, and lung cancer may become a major ctDNA battlefield as post-operative management gets smarter. And underneath all three is the same grand shift. We are moving from wait until the tumor comes back on a scan to watch the blood for molecular evidence that it is already trying to come back.
If you like this chat with the professor, please take a moment to click on subscribe for more like this. Also, if you could take a moment to click on the like button, That would help us to get this in front of many more people.